Well, it's great to be here again at EPICSEC 2019, and I have the privilege of speaking with Andrew Tochterman, who's the Vice President and General Manager of Image-Guided Therapy at Philips. Thank you for coming, Andrew.
A pleasure. Great to be here.
Thank you. Well, Andrew, we've known each other over the years, and I wanted to pick your brain a little bit about your experience through sort of initially Philips's acquisition of Volcano, and then how you guys have really focused on several niche areas rather than go very broad in terms of providing sort of therapies and image-guided approaches. So tell me a little bit about your philosophy at Philips and how you like to impact cardiovascular care.
Sure, absolutely. Well, it's been an exciting couple of years, going back to the early days of Volcano and being part of this quite a transformation, not just from Volcano becoming part of Philips, but a big transformation of Philips becoming more of a devices company.
Yeah.
Obviously a company that's rich in history with light bulbs and televisions and compact discs and many things that wouldn't necessarily be part of an interventional cardiology conference discussion, but it's really been a unique transformation for the company to now get into devices. And it really centers on the idea that if you look at how Philips positions itself throughout what we call the care continuum, we're looking at healthy living, we're looking at early onset diagnosis, we're looking at how we follow that diagnosis and patient information into the care setting, and then how do we help provide more precise care delivery in a way that we can get those patients back home to healthy, happy lives. That's kind of our goal.
Well, that sounds like a pretty broad goal,
Very
pretty
broad.
aspirational.
Well, we have to think big.
So let's put some meat on the bones
Sure.
here. So tell me about healthy living.
Okay.
So how does that early prevention start at Philips, or what specifically are you digging in on that side?
So certainly when we get into cardiovascular care, you can see that Philips has presence in things from toothbrushes, as an example, which is early preventative care for
Fascinating.
So from there, all the way through goods and services that help to support a healthier way to prepare food and whatnot. For us, in terms of cardiovascular disease, it really does start at a footprint of the onset of when a patient comes into the care setting and has chest pain. How do we help that patient get a faster, quicker diagnosis? And then how do we help them get home?
So tell me a little bit about sort of an area that's near and dear to my heart, which is intravascular physiology and imaging.
Yep.
Obviously, there have been a number of studies over the years looking at FFR for both diagnosis and prognosis, and really FFR has made it into the mainstream, I would say now. I just came out of a session where they were talking about post-PCI, IFR, and FFR. What has Philips's strategy been on that front in terms of how much do you guys insist on investing on technology versus clinical trials? And what's that relative interest and relative investment on those two fronts?
For a company like Philips, historically, the clinical trial investment would have been relatively low.
Right.
But now if you look at kind of trials like Define Flare, IFR Sweetheart, the most recent study on Define PCI at the American College of Cardiology meeting, there is a role for helping drive evidence to support the technologies that you bring to the forefront. So we're very excited about it. I mean, in general, our approach is, if you look at the totality of evidence that's out there that thought leaders like yourself, Bernard De Bruyne and Nico Piles and others have kind of brought Bill Fear on to the equation, yet despite all that evidence, we still see penetration of physiology remaining relatively low. Our overall philosophy is, how do we continue to invest in the right clinical studies to push that forward while figuring out from a technological standpoint, how do we strip away the things that make it difficult or frustrating to use physiology in routine care today?
And I find that really fascinating because there's always conversations about, accuracy, spatial resolution versus practicality. And ideally you want, technology that has everything, but frequently you have to make choices. So if you take a look at intravascular ultrasound, for instance, there are some devices out there that potentially have very advanced resolution, but may not have the practicality of a quick use. And I'm just trying to pick your brain about how you guys strategized about that, because I think, it's partly understanding the interventional cardiology psyche, but also understanding what sort of minimum level of imaging is absolutely adequate, but quick and practical. So is that a calculation you guys specifically
it's
made?
A very precise calculation, no, of course. But I think first and foremost, it's really understanding what are the key clinical decisions that need to be made. There's a lot of things in medicine that give us a lot of great information, but if that doesn't help change the way you're going to treat that patient, then it's good information at best. So it's always keeping in mind that perspective of what do you as a clinician practitioner care about understanding? How do we deliver that as fast and as seamlessly as possible with the right technological solutions, again, to help improve the patient care? So it's a delicate balance, but I'm always reminded of the book, The Innovator's Dilemma, which talks about case study after case study of large companies that over-engineered the marketplace to some degree. So, we have to, maybe that's heresy to say, and interventional cardiology is a field that's been so ripe with innovation and such a fast pace of innovation. But we've got to make sure that innovation remains meaningful to you, to your patients, to your staff, and then obviously now, especially today, to the healthcare system, which cares a lot about what it's going to cost them.
Another example of that sort of strategic decision making that you guys have to deal with is a technology that you guys have, which frankly is the only technology in the marketplace that allows us to assess coronary flow and coronary resistance, and hence usually is used in patients who have microvascular angina or endothelial dysfunction.
Sure.
I'm really passionate about that because I see a lot of patients that don't have obstructive disease and yet have really refractory symptoms that are life debilitating for them. And as you guys think about, how much to invest to upgrade the much needed upgrades in the equipment and the technology, you have to, on the one hand, think about the equipment, about the marketplace, but also the practicality and again, the psyche and the likely penetration of that in the marketplace. And I know you've been thinking a lot about that, so give us your overall take on that.
Well, I think it's nice to have a study like CORMICA, which was, I believe, at TCT last year, which showed us that stratifying patients between endothelial dysfunction and general microvascular disease helps us to better tailor treatment algorithms for patients. And so that when you see that, again, go back to the clinical relevance of the diagnosis, that only authenticates that diagnosis for its purpose. So, we see in dialogues with yourself and others that there is a patient need that a better diagnostic can help serve and stratify. And there is a lot of activity, I think, in the pharmaceutical community about better drugs and better medicines and better treatment paradigms for these types of patients. So I think all things are moving in the right direction. All that being said, and then reflecting on kind of our current technology, we have to remember that at the end of the day, if you've got a great diagnostic, but it's cumbersome, it's difficult, it's a separate piece of equipment, if we make it difficult for you to do it, then it's never going to really take off into the mainstream. So it's technology, it's evidence, and then it's making sure that the clinical need is at the heart of what we're doing.
Great. Well, even though I'm an interventional cardiologist, let me ask you a little bit about CT.
Sure.
Because it's everywhere you look nowadays with the PROMISE study and the Scott Hart study and the NICE guidelines and other things, there appears to be a movement towards non-invasive risk stratification, moving away from nuclear and echo towards CT. And certainly there may be some synergies between that angiographic assessment that you do non-invasively with intravascular imaging and physiology in the cath lab. So are you guys, obviously being a big CT company, right? Are you guys thinking of ways of leveraging your sort of non-invasive interest with the invasive and basically taking it out of the cath lab and upstream in terms of the early diagnostics? And how do you see those two modalities integrate?
Sure. I think I'll say it this way. The way that we've looked at that problem is whether we participate or not, it will happen. And most of the reason that we think that will happen is, it's kind of, just heard on the panel discussion moments ago, the family member question, which is if it were your family member entering the healthcare system and they had stable coronary artery disease or suspected chest pain, how would you put them on the right care path? CT seems like a great tool, and especially now with modalities like FFRCT that can help bring some function to the anatomical information you get from a CT scan, it does seem like it will be an efficient triaging tool to, let's say, streamline the diagnostic portion of the equation and better get the patient to the right care setting for the right treatment at the right time. So, and certainly in an era where artificial intelligence and machine learning are moving faster than any of us can catch on to the new phraseology, it's going to move quickly, and we think it's going to be quite disruptive. So we as a company see that those market dynamics and think it's going to be a great thing for patients, probably a very good thing for the healthcare system, and certainly we looked at see how we can best participate.
Yeah, well, no, that's great. What about the idea of co-registering the non-invasive images with the cath lab? I think both for structural heart disease as well as in the coronary space. Just this morning, we were doing this complex CTO, and there was a lot of calcification, and we just in terms of understanding that, the question is how can you do better pre-procedural planning, and can you leverage that in the cath lab if you can co-register your CT with your IVUS and your angiogram and essentially make the procedure safer and more efficient. And of course, in the structural space, that's even more relevant. So is that an area of focus for you guys?
Absolutely. There's a couple of, I'd say, small examples of where we are doing this. Technologies like Echo Navigator, an example where we're fusing together two what were once standalone pieces of information. The co-registration technology, which takes the angiogram plus the physiology, or the angiogram plus the intravascular imaging. These are examples of just, I'd say, small steps in the idea. But again, go back to kind of Philip's broader strategy of participating in information along that care pathway for the patient. If we don't bring that information together in a useful way, then shame on us, because we do think that when you are treating that patient, whether it's a structural heart procedure or a PCI, you're integrating the information already. So we think it's the way that physicians are thinking about treating their patients, and if we can do it through technology to make that interpretation easier, simpler, faster, then certainly we're going to look for ways to do that.
Well, great. Well, listen, one of the reasons I really want to interview leaders in industry like yourself is we think that it's really a partnership between the healthcare industry, the physicians, all the healthcare providers, and we fully acknowledge that, and to serve our patients, we've got to talk to each other, we've got to have dialogue, and I hope lots of people listen and get inspired by the work that you guys are doing to help our patients.
Well, likewise, we appreciate the opportunity to have these types of dialogues. We couldn't agree more that partnership is paramount if we're going to continuously improve.
Great. Well, it's good chatting.
Thank you.
Okay.
Likewise.